So we shall go on to our last but not the least, Dr. Manju Pillai, another pillar of glaucoma department of Arvind Eye Care Systems, Madurai, and she is going to dwell on a very difficult situation, a difficult ophthalmus. On to you, doctor. Could you unmute?
Can you hear me now, ma'am?
Yeah.
Okay, so it's the last presentation. So here I'm just presenting a small case series.
What signal is poor?
The next slide. So it's a siblings of case series, like a 2-month-old male child presented with left eye watering and born to non-consanguineous parents, and it was a full-term cesarean session with a normal antenatal and neonatal history. And on clinical examination at 2 months of age, there was a megalocornea in the right eye and cataract in both eyes, and intraocular pressure was 11 in the right eye and 22 in the left eye. And right eye had an axial length of 18 and left eye was 90.49. So we diagnosed as a bilateral congenital cataract with glaucoma and started a treatment with anti-glaucoma medication of topical dorsal and scheduled an examination under anesthesia. But the child was lost to follow-up due to COVID-19 and lockdown restrictions, and there was a poor compliance to medication. And came for review after 6 months, that was at 8 months of age, where they had not used the medication. The pressure shot up to 41 millimeters of mercury and axial increased to 20.16. And the cataract was dense, and this was the picture in the left eye. So on systemic examination, there was a delayed milestones, and CNS noted a hypertrophy with a global developmental delay. When we took the family history, we also noted that the brother had some eye problem and he had undergone treatment in both the eyes and he lost vision in the right eye. So we called the parent for an examination and checked his case sheet, and he also had a defective vision at 15 months of age and the similar history, delayed milestones. And both there was a record of sequential cataract surgery done and both on anti-glaucoma medication. And thought screening was positive for the brother, that was IgG for CMV, and traction largely in the right eye, and left eye showed an RP modeling, and ERG showed a reduced rods and con amplitude. So on examination of the elder brother, it showed that the right eye was aphakic and left eye was aphakia with a normal disc, and intraocular pressure was borderline with 24 and axial length was stable. And this is a picture of the elder brother. So for the baby, we did the investigations. All the basic investigations were normal, and the TORCH screening showed a high positivity for CMV IgG. And examination of the parents, mother showed a posterior polar cataract in the left eye. And so the common features in both the siblings were congenital cataract, glaucoma, delayed milestones, and IgG CMV positive. So now, what was the etiology and diagnosis for these children? Which eye to operate first? Whether to do a glaucoma surgery first or the cataract surgery. So EO of the second sibling showed under anesthesia the 10 pressures were 33 in the left eye with all enlarged and axial length was 19, and right eye had a dense cataract in the visual axis. So we restarted the AGM fixed combination and went ahead with the right eye cataract extraction, and 2 weeks later I underwent a left eye RP surgery. So this is a picture. First was the cataract, and this is after the cataract extraction, and this is after RD where the cornea has cleared up. Now we are going to be taking it up for the left eye cataract extraction. So here the challenges were diagnosis, treatment of glaucoma and persistent cataract, and the investigations that we need to do. So diagnosis, whether it's a congenital infection, and if there's a congenital infection, we got CMV as when we were checking, and the Sushmita Kaushik's article shows there is a rubella and a concomitant rubella and a CMV infection for a child with a glaucoma and cataract. and the enhanced CMV infection, cytomegalovirus infection in Dracula measure, and another one with a congenital CMV with glaucoma. This is a little rarer, and the incidence of congenital infection increases. In the first is 90% in the first 11 weeks, and it's 100% in the last month of pregnancy. And rate of congenital defects is more in the first 11 weeks of gestation. And pathogenesis of glaucoma in congenital infections, it causes abnormal development of ankle secondary to either side, secondary to cataract or following cataract extraction. CMV infection is the most common intracranial infection, but it causes cataract rarely. And it mainly affects the choroidal retinitis. So if it's an inherited disorder, then there are two diagnoses that we can make. One is the Lewis syndrome, or second one is the Nance-Horan syndrome. Nance-Horan syndrome, we need to look at the dentition, and Lewis syndrome, it has congenital cataract and glaucoma, and females act as carriers, and we need to do investigations. So the take-home message is a proper family history taking, screening of parents and siblings are essential. Differential diagnosis and appropriate investigation needs to be done, and treatment plan needs to be scheduled well for treating coexisting cataract and glaucoma to preserve the child's vision and to treat glaucoma progression. So thank you. Thank you, ma'am.
Thank you very much, Dr. Manju. Dr. Shushmita, are you there? Hello?
Hello, yeah.
Yeah, Doctor, because there was a lack of clarity, so I wasn't sure whether Dr. Manju could hear my question. How early would you implant tube in these cases if the need arises? And the second question is, would you look at a 360-degree trabeculectomy or versus harms?
So a 360-degree trabeculotomy, apparently those who are doing it, especially with the eye science now, at least in more fields, they have reported no failures at all. So intuitively, I would think that a 360, if we can do it, maybe a GAT, as Rashmi was saying, the initial trials at GAT haven't been very successful. I've managed about 180, but not 360 as yet. But the more angle you treat, the more likely it is to get better. So definitely, if we can get hold of it, a 360 would be more. Regarding tubes, as we all grow over the years, the enthusiasm for invasiveness decreases and conservativeness increases. And 10 years ago, I would have been all gung-ho about putting the tube anywhere, but you realize that with children, with a growing eye, there are problems of tube migrations, of movement, of rubbing, and the cornea generally does take a toll on it. So I would be very conservative in putting tubes in small babies, unless absolutely. And in fact, limited diode laser cyclophotocoagulation is much lesser invasive for the children. We do about 180 degrees or even less, 150 degrees in the failed cases, of course. I mean, so we start off in a white cornea. I would start off with a combined trap with trap, and many times the cornea clears, but the pressures are not good enough. So we do goniotomy in the second because you have the rest of the angle. And in many, many cases, that's enough. We can go on to even a third goniotomy at times. So if you have a 360, that'll help. But tubes are, I would be more comfortable doing them in secondary glaucomas where I know the other eye is completely normal, especially if they're pseudophakic. There it's okay. But for primary tubes, I'm a little hesitant now. I think Dr. Vijaya is smiling because she's seen us grow and then talk the same thing that ma'am used to tell us, and now we've all realized that how true that was.
So any other questions from the expert panel? Dr. Vijaya, Dr. Tanuj, Dr. Craig, it's sorry that we couldn't take some more questions with you. Thank you very much for having been with us till the end of the event. Dr. Vijaya?
Yeah, nothing specific. I think quite late for everyone, and thank you very much. And I hope it was.
So I think it's quite late, so I'll give my conclusive marks. It's been a truly an amazing webinar because there was a wide gamut of topics so beautifully discussed. And I think we owe it to all of you, all prolific surgeons and teachers in this group for making it so special. Special thanks to my co-moderator, Dr. Murli, for his constant support all through. My thanks to my special ARC team. Thanks to our admit team of AIOS led by Mr. Kripal. Of course, Mr. Sunil, who's the webinar admin, who has been associated with all of us throughout this early part of the planning and course of the webinar. Sai and Manjula from Numerotech, and a very special thanks to the entire team led by Mr. Nikhil, who have been our main sponsors for every single ARC program this far. Very special thanks to our attendees who gave us the energy to keep coming back again and again with more useful webinars. Thanks a lot. Thank you very much, one and all of you in this very expert panel and speakers. Thank you.
Yeah,
Thank you, Dr. Chitra. Thank you.
A lot.